Now, let's go into more detail what can be done to help those people. Conservative treatment, we talk about it. Uh, young, as far as the operative treatment, most of those people are young patients. Although this is quite successful, but there's limitation with it. And the long term, people might develop backache, or when they develop backache, it will become troublesome them to have a fused hip. Hip replacement is associated with poor results in young people, and it should be offered only for end stage failure. I remember if you put a hip replacement 20-year-old guy, probably he's going to wear it even in a very short period of time. Then you had to revise it, and you revise it, and you're in a stage where there's no bone left to revise anything. Pelvic and femoral osteotomy might be the procedure of choice for such people. And the idea of this osteotomy is that people with hip dysplasia, they develop osteoarthritis in a few years' time. So this is a patient here. We expect him to develop some sort of severe osteoarthritis in 6 to 7 years, and the aim of the procedure is really to delay this as long as you can, 10, 15 years, and this buy him some time before he needs a total hip replacement. And in fact, if you pick them early, particularly the mild one, less severe than this one, well, you might prevent it till they die, basically. So there's hip dysplasia, the triradial cartilage open, probably triple osteotomy. If it is closed, you'll go, the portion of choice is periacetabular or Gans osteotomy. Acetabular impingement, they might need osteoplasty. So surgical technique for periacetabular or Pyrenees or the Gans osteotomy. Periacetabular is the anatomical description. Pyrenees related to Bern, the city where first publicized, and Gans related to the professor who developed it or who involved in publicizing it. So basically what it involves is cutting all the attachment and rotating the socket to orient it in a better way. This is the way you position the patient. This is a nerve monitoring for the lateral cutaneous nerve of the thigh, TSP spine, the line of incision. The first step is to cut the ischium partially. Okay, and this is the way you do it, and usually it is a blind cut for this. You feel where the ischium is and you cut half of it, as shown on this model there. Then you cut the whole superior pubic ramus, and this is usually open. You can see it and you can cut it. Then you start cutting the allium. What you do, you drill a small hole there and you direct it to there, and you know when you reach there you stop there. Then when you stop there, you try to twist it vertical, almost 110 degrees, to reach the partial cut of the ischium. And what you end with, this is the socket, this is complete cut, this is partial cut, but if you look at from behind, it goes all the way around the socket. This is femoral osteotomy. Sometimes you can do femoral osteotomy with it, but it's not always necessary. But if you go back to this one, although the socket has come out, the posterior column is still intact, and this is the main part, the most important part of Gans osteotomy. The posterior column remain intact, so the patient can sort of weight bear or partial weight bear early, as there's no discontinuity of the pelvic ring. And this is the X-ray picture. Ignore the fact there's some femoral osteotomy going there, but this is what the picture. This is this socket rotated this way. You can see this goes up, this is open a bit, and this one almost in the same continuity. Indication for femoral osteotomy in combination with periacetabular osteotomy, usually if there's a femoral deformity or some sort of femoral acetabular incongruity or impingement, or there's subluxation after periosteal osteotomy. So this is another procedure to help better orientation of the joint. Now, when I was Mr. Dikiut registrar, I reviewed his patient who underwent cancer osteotomy. Mr. Dikiut done around 50 plus patients, but for different reasons I couldn't get more than 25, either because of coding thing or because of wrong name. So I looked at those 25 patients and collected clinical data and radiological data. I looked at the demographic data, clinical evaluation, perioperative information, and I looked at all early and late complication. Also, I looked at the preoperative and postoperative central age angle. I looked at the Tunis angle, and I looked at the complications on X-ray. Mean age for the patient was 25, ranging from 18 to 41. 12 right side, left 10, and 3 bilateral. Anesthetic time, average was 34.84 minutes, and range was 20 to 62 minutes. Operative time was 173 minutes, range 150 to 325 minutes. So it is not a short operation, it takes around 3 hours. Median length of the stay was 9 days and range from 6 to 24 days. So it needs some good rehabilitation immediately after the surgery. Average hemoglobin drop was 4.86, range from 2.8 to 7.5, and the significant number of people, at least two-thirds of them received blood transfusion. 8 didn't receive any blood transfusion. 2 of them received 6 units each. When I look at the radiological signs, you can see this is Tunis angle has improved from 25 to almost 10. So from vertical to more horizontal, which is favor cartilage biomechanic. Central age angle improved from around 15 to average 38. And we use the Eurocall quality of life assessment, and with Eurocall the lowest value the better outcome. And you can see this is for example the mobility, preoperative mobility and postoperative mobility moved from almost 2.3 to there. So you can see there's improvement in all parameters. Complications, there were 2 non-union of the ischium, needed ORIF, and both went into full union. 1 symptomatic non-union of the pubocramus, which was ignored. 2 patients needed Birmingham hip resurfacing within 5 years from the surgery, and there was 1 heterotopic ossification. And there was 1 lateral cutaneous nerve of the thigh, which is fully recovered. That's the end of the presentation. Thank you very much for listening, and please do ask any question.